Today my lecture is on oxygen therapy. Why do you think it is important to talk about oxygen therapy? Emarka, you can answer. You have Emarka in your batch, ne?
Yes, madam.
Emarka is it? Sorry.
Yes.
So why do you think we have to talk about oxygen therapy?
Oxygen is needed for life, and in critical care we
use a lot of oxygen, isn't it?
Yes.
Not only in critical care. In an emergency, what is the commonly used drug you see?
Oxygen.
That is oxygen, isn't it? In anesthesia, when you do the anesthesia appointment, you'll see that how much oxygen we use, isn't it?
Yes.
But ultimately, when you talk about oxygen, the oxygen is mainly needed for your aerobic metabolism, isn't it? You all know this now. So when glucose is metabolized in the aerobic metabolism pathway, it gives you 38 ATPs. But when it shifts into an anaerobic metabolism, it gives you only 2 ATP, isn't it? So it is not efficient if it goes into anaerobic metabolism. Okay, that is why you need oxygen. How do you explain the way that one molecule of oxygen is delivered into your tissues? So here I have shown you that there are factors that influence your oxygen delivery to tissues. That is your adequacy of ventilation, pulmonary gas exchange, and the adequacy of your circulation, and all those things matters. And if you fail to deliver oxygen to tissues for about 4 minutes, tissues become hypoxic. And what happens when the tissues become hypoxic? Dulita, what happens when the tissues get hypoxic? What do you think happens?
Madam, they are going to face ischemic damage.
Very good. When the cells are ischemic, in the long run, they can die, isn't it? When the adequate number of cells dies, the organ is going to malfunction. So what is the first organ that dies very quickly? You're worried. The organ that you're really worried.
Brain?
Yep, good. And what is this? You all have seen this, isn't it?
Oxygen cascade?
Yeah, this is the oxygen cascade. And this is where we talk about ventilation, where oxygen is driven from atmosphere into the level of alveoli, from alveoli to the arterial blood gas. That is where we talk about the gas exchange, isn't it? You all were taught about this, isn't it? And when the gas exchange occurs later, the oxygen that is bound onto hemoglobin and some will be minute amount will be dissolved in blood, and that will be circulated in blood, isn't it? So we use this oxygen cascade to talk about the oxygen delivery. So then the question comes, why do you have to give oxygen? So as you all said, we give oxygen when the requirement is high or when the delivery is not adequate. So you said we give oxygen in the emergency department. So what are the situations that you have seen a patient on oxygen? Tilina, have you seen patients being given oxygen in the emergency department or in the wards? Oh, where's Tilina?
Respiratory distress.
Yeah, when the patient is in a respiratory distress.
Yes, madam.
Okay. So what are the instances you have seen a patient on oxygen? Have you seen patients being given oxygen? Tilina, you can unmute your mic. I think you are still on the mute. Okay, someone else can answer for that question. That is a pretty easy question. Anyway, if you all are wondering why, here it is. So we call it, we have two terms actually, hypoxemia and hypoxia. What do they really mean? Pawan Tisara, I think. What does it mean to you when I say hypoxemia and hypoxia?
Hypoxemia is oxygen saturation in the blood.
Good. And hypoxia is?
In the organ level.
Very good, at the tissue level. So when you have very reduction in the oxygen in the blood, which is generally we talk in terms of PaO2, which means the partial pressure of oxygen. Got it? When it is less than 60 millimeters mercury, we call the patient is hypoxemic. Or if you talk in terms with saturation, which is SaO2, when it is less than 92 on normal air, we call the patient is hypoxemic. So for a patient like that, you need to give supplementary oxygen. And there are some situations where you think that the patient is at a higher risk of hypoxemia. When the patient has some lung pathology and patient has some defect in oxygenation, so you think they are at a higher risk of hypoxemia. So these people also need oxygen. And in a case of trauma, when they have a higher demand, when the heart rate is very high and the demand is high, you need to give oxygen. But what is the problem with an acute MI? Do you always give oxygen for a patient with acute MI? We are not sure. We will discuss that later then. And when the metabolic demand is increased, situations like burns, severe infection and multiple injuries, those patients too need oxygen because of the high metabolism. Okay. And the most important thing I want you all to remember today in my lecture is that oxygen is also a drug. When we are talking about drugs, when you are prescribing a drug, what are the things you think? I mean, what are your concerns? Who's going to answer? Suvini Vijay Singh. Hello. Someone else can answer that question. I just took a random name. Anybody else can answer that question. When you're prescribing a drug, just say you're prescribing paracetamol. So how do you write it? Can you all hear me? Did you all think about my question? As to what are the things you're concerned when you're thinking about a drug? Who's going to answer? Just say paracetamol. What are the things you consider when you're telling somebody to take paracetamol? Yeah, you need to talk about the dose. What else?
Possible side effects.
Very good. You need to think about possible side effects. What else?
Route of administration.
Good. Route of administration. Are you worried about the indications and contraindications? Do you always think whether it is indicated for that patient or not? Isn't it? Why? Why are you so worried about the dose, the frequency, and all those things? Any drug in excess can be toxic, isn't it? So, likewise, oxygen is also a drug. Though it is freely available and it is very commonly used, you need to remember that it is a drug as well. So, when you're prescribing oxygen to a patient, there has to be a proper prescription. And you have to have a way of administering oxygen. And when you give a drug, you always monitor the patient. As somebody said, that there can be side effects, isn't it? So, when you give oxygen correctly, it is a very much of a life-saving drug, and if it is too much, it can lead to toxicity as well. And if it is not enough, again, your problem is not sorted, right? You are giving it to relieve a patient from hypoxia, or you will be giving it to a patient who has a high demand of oxygen to prevent hypoxia. So if you give too little, again, it is not going to be effective. So, like any other drug, when you give, you need to consider about the indication and the method, and above all, you need to have some target set. Got it? So, generally, the prescription should cover the flow rate, the delivery system that you are going to use. As you said, if you think of another drug, you talked about the route, isn't it? When we give oxygen, we use the route of we use the airway, but there are different delivery systems. Like different routes, you have different delivery systems. And like your frequency, you are going to write about the duration. How long are you going to give this drug? And you are going to monitor if the treatment is working or not. Understood? So here are some goals. We have discussed about this slide previously, so I'm going to move. And to identify the indications, you need to assess the patient to see whether the patient has a risk of hypoxia or whether the patient is hypoxic. So I have listed few clinical features, and I can see that. Have you all seen a patient with patient who is hypoxic during your clinical appointment? I can see Pavita's name. Pavita, have you seen a patient with hypoxia? You thought that the patient is hypoxic when the patient is in the ward?
Yes, madam.
So how did they look like?
They look like restless and short of breath.
Very good.
They may be cyanosed also sometimes.
Yeah, maybe. If they are very severely hypoxic.
They may be confused. They don't know.
Okay. Good. And if the patient is acutely hypoxic, you see all these things. And when the patient is chronically hypoxic, they can't, if they are significantly severely hypoxic, they cannot stay a long period without some support. But chronic hypoxic patients can be very fatigued, drowsy, and they might not be able to complete their task. And do we have any other methods of assessing whether the patient is hypoxic or not? Again, Pavita can answer that question, I think. These are the clinical features we talked about. Are there any other methods that we can use to assess whether the patient...
Oxygen saturation?
Very good. You can use the oxygen saturation. So how do you check the oxygen saturation? With what? What are the devices?
Using pulse oximeter?
You can use the pulse oximeter. And anything else? There in the slide, we can do a blood gas analysis. Have you seen a blood gas being done? Arterial blood gas, not a venous one. Have you seen they doing arterial punctures and collecting blood? Others, Kasun? Kasun? I think Kasun is here, isn't it? You can unmute. So have you seen the blood gas being done?
No, madam.
No. Okay. When you go to one day when you come to our anesthesia appointment, or if you happen to go to an ICU, you will see that daily we do blood gases and blood gas analysis. To analyze these gases, we collect blood from arteries. So when you collect an arterial sample, actually you can measure the real partial pressure of oxygen that is dissolved in blood there. And you have saturation can also be seen in the report. And there's another thing called lactate. Why do you think we have to take lactate into account when you're talking about hypoxia? Why do you think it is, Kasun? Why is lactate important when we talk about hypoxia? You can work it out with your physiology knowledge easily. I know you know more than me
In
about it.
hypoxia, madam, anaerobic respiration takes place and lactic
Yes.
acid is produced.
Yes. So when lactic acid is produced, if the lactic acid level is very high, we know that there is some degree of tissue hypoxia, isn't it? So this is a very good marker of tissue hypoxia that we commonly use in during our patient management. Okay. So as I said, we need to set targets. So that is because I said hypoxia and hyperoxemia both have adverse effects. So adverse effects of hyperoxia, I'm sure you have not you don't have much experience with these aspects of medicine yet. But when the patient is being given a very high percentage of oxygen for a long duration, there can be with your metabolism there can be a production of reactive oxygen species, and they can actually damage your DNAs, RNAs, and can damage cell membranes, and then the cell integrity would be lost. So the clinical features in this affects mainly again your respiratory system, and not only the respiratory system, generalized vasoconstriction can also occur. And in the longer run, if a patient is on oxygen for a long duration, there can be lung injury, acute lung injury, as well as fibrosis of the lung. And there's the entity called absorption atelectasis. I think it is very easy to understand. Where if you give 100% oxygen into an alveoli, generally at the level of the alveoli, what do you think are the gases that are there inside an alveoli? What are the gases? Damsara. Oh, Damsara. What are the gases there inside your alveoli? Hello, can you hear me? Damsara. Can you answer my question about the gases that are there inside an alveoli? Anyone else wants to answer that question?
Madam, there can be oxygen, carbon dioxide, and nitrogen.
Very good. You have mainly those three gases are there, and the alveoli. When nitrogen is there, does nitrogen diffuse into the blood very easily? It doesn't. No, we just don't talk about it that much. No? So when you give 100% oxygen, the difference is that is when you're breathing normally, isn't it? So when you give 100% oxygen, just imagine you are giving 100% oxygen. So the alveoli will have only oxygen like. So and some carbon dioxide will be diffused back from the blood. And when there's lots of oxygen, the oxygen can diffuse into your blood, collapsing the alveoli. So when the alveoli are collapsed, we call it atelectasis, and because this is happening with an absorption, that is called an absorption atelectasis. Okay. So have you all heard about COPD patients? Who's there? Sanjeevani. Have you seen COPD patients? COPD means patients with chronic lung diseases. The chronic smokers, they come with a obstructive disease called chronic obstructive pulmonary disease. Have you all seen such patients?
Yes, madam.
Okay. So in your physiology, you have learned what is the stimulus for your respiration, the most potent stimulus for respiration in your body, the gas actually for your skin.
Carbon dioxide.
Okay, good. When carbon dioxide is retained for a long time, what happens to your respiratory drive? with carbon dioxide?
Stimulate inspiration.
Okay. Anything else that happens for a shorter period? If it is high for a shorter period, it would stimulate respiration. Very correct. But if it stays for a longer period, like in a patient who has a chronic lung disease for a longer time, who retains carbon dioxide for a longer duration, like for years and maybe months, and what about their respiratory drive? Is it driven by carbon dioxide only?
No, madam.
No. So what is the gas that drives their respiration?
Oxygen, madam.
Oxygen. Okay, so that is why I wanted to talk about these targets that much. When you're talking about oxygen therapy targets, we need to talk about those type of patients who has a respiratory drive with oxygen as well. Okay, because when you give a lot of oxygen to those people, what would happen to their respiratory drive? That is oxygen, in the sense lack of oxygen is the stimulant for them, isn't it? So if you abolish that stimulation, what happens? Pawan.
Respiration stop. The respiration is the respiration center get deep.
Yeah, center would get depressed. So that is why you are not going to. That is why we have different targets for different groups. So one such target is if the patient is a previously well patient and who is acutely unwell, we go for a target saturation of 94 to 98%. Okay. For a healthy person, 96 to 98 is enough. The normal value is we generally take 98, 100. Those values are normal, but we have these targets above 94 for a very normal patient who is acutely unwell. We generally take it as all right or normal. But for that is your target, right? So you are going to achieve that target by giving oxygen to a patient who is hypoxic, who is previously well and hypoxic. But for a patient, as we discussed earlier, who has a risk of hypercapnic respiratory failure, means patients whose respiratory drive is through a hypoxic drive, like COPD patients, that means a very severely ill lung, whose respiratory drive is maintained with hypoxia, you are not going to abolish that drive. So you are going to accept a lower target for them, that which is about 88 to 92%. Did you get my point? All of you? Can you hear me? Do you want me to explain it again? I hope not, isn't it? So I'm going to move on. So now we know the targets and we are going to set the therapy. So like you're starting some drug, you need to have a source, like source of oxygen. And you need to have a delivery system, and you need to have a monitoring frequency, or you need to decide on the adequacy of therapy, way of deciding the adequacy of therapy. So there are different sources we have. One is oxygen cylinders, and there are pipelines. Have you seen these oxygen cylinders? Anybody? Subodh? Have you seen oxygen cylinders?
Yes, madam.
Okay, have you seen these pipelines? No. Have you been to the Peradeniya theatre? Peradeniya Hospital Theatre, the main hospital? No, not yet. Anybody who has been to the theatre? Is there anybody who has been to the theatre? Just to see the theatre even? Not anyone? So sad. It's okay. Next time, if you happen to go to the theatre, you can see that there is a very big white color tank situated behind the theatre complex, actually at the behind the recovery area, and that is a big liquid oxygen tank where we get oxygen from. Not like those small cylinders, that is a very big one, and that delivers oxygen to the whole theatre through a set of pipelines. So that is why I said these liquid oxygen can be delivered in the form of gas. You deliver them into the anesthetic machines and theaters because we use a lot of oxygen. Otherwise, we'll have to change these small cylinders very frequently. So we use the oxygen pipeline system. Okay, and there are delivery devices. Like the route of drug, I said you need to decide on a delivery system. So there are different factors that determine the suitability of a delivery device to a patient. Those include the patient's acceptance. If the patient says no, never, I don't want this, you can't just keep them like that because the patient will be in a big distress and they would try to fight with you. So the patient acceptance comes into play, and the level of your FiO2 you need. FiO2 in the sense fraction of oxygen. The normal fraction of oxygen in air is, how much is it? How much is it? Normal fraction of oxygen in air?
21%.
21%. So you call it 0.2 fraction. When you call it as a fraction, 0.21. Okay. 21% means when you take it as a fraction, 0.2. Good. And then whether the patient's respiratory effort and the level of humidification and the availability is a big factor that determines the choice of your device, and the efficient and whether you can use oxygen in an economical way has to be thought of as well. So depending on these things, these devices are categorized into different classifications. So there can be overlaps, right? There are few devices and they are classified in different ways. So we can differentiate commonly. We categorize them saying fixed performance devices, or we sometimes say and variable performance devices. And sometimes we divide them into high flow devices and low flow devices. And sometimes we call some equipment positive pressure devices. And so there are lots of classifications, but you don't have to worry because there can be overlaps. Like when you say some devices can come into two categories, like they can be a low flow device and can be a variable performance device likewise. Okay, so I will be mainly talking about this classification where we classify devices into fixed performance devices and variable performance devices. I will tell you what do these words mean in my next slide. So as I said, this is how it is divided into low flow devices and high flow oxygen devices. Low flow in the sense these devices, nasal cannula, simple mask and Venturi mask. I will show you what are these devices. They use relatively a lower rate of oxygen to deliver the desired amount of FiO2 in contrast to the devices that are listed below, like high flow nasal oxygen and non-invasive ventilation, where we use a higher rate of oxygen. Like when you talk about the oxygen flow rate, you talk in terms of liters per minute. Here, for a nasal cannula, you might use about 2 liters per minute, whereas in high flow nasal oxygen device, sometimes you might go up to 60 liters per minute. That is how it is divided. Understood? So, likewise, sometimes, as I said, the commonest classification is with variable and fixed performance devices. The term variable means the fraction of oxygen that is delivered to the patient varies with several factors. When the device that you are using the fraction of oxygen that is delivered, if the fraction of oxygen that is delivered varies with the patient factors and the oxygen flow rate and the device factors, those type of devices are called variable performance devices. Understood? Students, anybody say yes or no? Yes.
Yes, madam.
So these devices are kind of very commonly used devices. You have nasal catheters, cannulae, and simple plastic mask. We'll see whether you have seen these devices. This one is called nasal prongs. Have you seen this on your patients?
Yes, madam.
Or else in some movies you have seen it, isn't it? So patients who are on oxygen at home, they are sometimes on this device. So what do you think about this? Does it look comfortable for the patient?
Yes, madam.
That is why they use it at home now. So one of the advantage of this device is the comfortability, and the patient's face is not actually covered. They can actually eat, talk, and they can actually mobilize even with some aids with this if the patient is on this device. And actually it can deliver only about 24 to 30% oxygen to the patient, and the flow that you use is about 1 to 4 liters, not more than that, because this is put into the patient's nose, and if you give a very high flow rate, it would be very uncomfortable for the patient because it is directly delivered into your nose. Okay, so the disadvantage is you can't go up on your fraction of oxygen. If the patient needs about 60% of the oxygen, by giving oxygen, actually we are trying to increase the fraction of oxygen that is delivered to the patient. Okay, so that is why I'm always talking about this fraction of oxygen, and there can be a risk of damage to the patient's nasal mucosa. Okay. And these are called nasal catheters. Can you see the picture below?
Yes, madam.
I think you have not seen this device previously, isn't it? This is not very commonly used, but sometimes we use this, and similar advantages and disadvantages are there to the nasal prongs. And this one is a simple face mask. This is what you have seen very frequently, isn't it? So this device is again a variable performance device. Can you see that depending on the flow rate, the fraction of oxygen that delivers is changed? Can you appreciate it? So advantages are it is somewhat cheap and it is available in every ward setup, in ICUs and theaters, everywhere it is there, and it can deliver, it says it can deliver about 60%, but in practically it is not so. We might not be able to go above 50% of oxygen, but the disadvantage is sometimes people do not like to keep a mask on their face. And they need to remove if the patient wants to talk or eat or drink, and sometimes the irritation to the eyes can occur because the gas can leak around the mask. Okay. Any questions on variable performance devices? Okay.
Excuse me, madam.
Yeah.
Even something like nasal prongs, they deliver oxygen at a certain rate, but how would it vary according to the patient's respiratory rate? Because anyway it delivers at a constant rate, madam.
Yeah, that is when we talk about variable performance devices, it is not only the rate that we are talking. It is the patient's effort and some device factors as well. If I explain it, it is going to take a bit of time. It is like there are other things that we consider, like the patient's peak inspiratory. There's a thing called patient's peak inspiratory flow rate. Have you heard this term previously? Have you not? So it is something like when you breathe spontaneously, you take a breath, and that breath is actually it varies with some pressure changes, but at a point there would be a rate where the patient takes their breath at the patient's maximum rate, which is generally we call about 25 to 30 liters per minute. So this doesn't mean that patient takes 30 liters, but the rate that they breathe during that time is something like that. Okay. The person who asked the question, can you please tell me your name? I couldn't follow you. Hello.
Yes, madam.
What's your name, sir? I didn't get your name.
Pavita, madam.
Is it Pavita? Pavita, okay. And your peak, there's a thing called peak inspiratory flow. Okay. And when you supply oxygen, just say you are giving 4 liters per minute oxygen through a device which consists of 100% oxygen, isn't it? When you're giving oxygen, that is pure oxygen that you're giving. No? So just think about this peak inspiratory flow, which I said, which is about 25 to 30 liters per minute. But the patient's tidal volume is about 500, but this is the rate at which the patient takes gases, I'm talking. Okay. So if you're giving the patient about 5, just say 5 liters for the ease of calculations, I would say 5 liters per minute. And if the patient takes about 5 liters per minute, the rest of the gases should come from the air, isn't it? Understood, Pavita? So
yes,
at the peak inspiratory rate, just say 25 liters per minute, patient needs to take 25 liters for the moment, we'll say like that, and 5 are being given like pure oxygen. The rest 20 should come from the air, so which is called an entrainment, and that air contains only about 20% of oxygen. So there would be a dilution of oxygen when it is being delivered to the patient. That is because the patient, it is not only the patient's peak inspiratory flow or the amount of oxygen that is delivered to the device that matters, the entrainment also matters. Okay, if I show it to you in a diagram, can you see me now? Can you see the diagram that I have drawn?
Yes, madam.
Okay, this is what I said, right? This is the patient here, and he's taking 5 liters from the device that you're giving, and the rest is coming from the air, which has about 20% oxygen. So there is a dilution, so that the amount of oxygen that goes to patient is going to change with the amount of the rate of oxygen that is delivered by the device. That is how it happens, right? If you calculate it, you can actually calculate the fraction of oxygen that goes to the patient. If the patient is not on any oxygen, the whole 25 to 30 liters would be taken from the air, right? But if you have another device where it delivers 10 liters and the dilution is going to be different, that is how the fraction of oxygen that is delivered to the patient differs depending on the device factors. That is why those devices are called variable performance devices. Okay.
Okay,
In
madam.
contrast to fixed performance devices. Whereas in fixed performance devices, this ratio of entrainment is actually designed by the manufacturer, and it is a fixed proportion. So the fraction of oxygen that goes to the patient is going to be somewhat fixed. Like here, in this case, in a variable performance device, if the patient's efforts are not adequate, like if the patient cannot generate a peak inspiratory flow of 25 to 30, instead if he generates a peak inspiratory flow of about 10, or if he generates a peak inspiratory flow of about 50, it is going to affect the fraction that the patient actually gets at the end, isn't it? Got it? So these three variables are going to decide the fraction that the patient is taking if it is a variable performance device. But if it is a fixed performance device, these things are pre-decided. The fraction that is being entrained is going to be a pre-decided one. So the patient is going to get a fixed fraction of oxygen. Okay. Did I answer your question?
Yes, madam.
Okay.
Yes, madam.
Nice. And I'm going back to my presentation, and now it is very easy, I think, to explain about the fixed performance devices where the fraction of oxygen is somewhat fixed, and there are different masks and gadgets that we can use. Of them, the commonest one is Venturi mask. Have you seen this mask previously? This one? Probably, isn't it? But you have not realized that it is a very sophisticated one until I tell you now, isn't it? So these devices, they are kind of color coded, and there is on their device it is stated that the amount of oxygen, the fraction of oxygen that is delivered to the patient. For instance, if it is the green one, it says 60% at a flow rate of 15 liters per minute. So if you want to get the desired fraction of oxygen to the patient, you need to adhere into the flow rate that is recorded, that is actually labeled on the device. Okay. So next time when you see a patient on oxygen, just check whether they are on these devices. This is very important when you talk about that COPD patient who has, that we have the patient who has a respiratory drive through who has a hypoxic drive. So you have you heard the term controlled oxygen therapy? So when you want to actually control the fraction of oxygen delivered to a patient, these devices can be used. Otherwise, if you use a variable performance device, you really don't know how much oxygen you're giving to the patient. But here, when it is a Venturi device, if you want to give a little bit of oxygen only, you can use this 24% or 28%, depending on the patient's condition. You can decide what to use. Okay. And here, this is in the same thing again. And advantages are, you know the fraction of oxygen that is delivered to the patient. But the problem is, can result in some skin irritations because of the mask, and may be a bit uncomfortable for the patient because it uses a bit of a higher flow. And there's another mask. Sometimes you might have seen this mask where there is a large bag attached to it. Like in your ambu bag, there's a bag attached to this mask. Has anybody seen this mask being used? Okay, looks like no, but next time when you go to a ward or somewhere, just ask whether they have this type of mask, and you will see that this mask is a bit different because it has some valves and it has a large reservoir bag attached to that mask. So because of some manufacturer properties, these properties in the bag, you can deliver a kind of a very higher percentage of oxygen to patients, like 95 to 100%. You can deliver through this mask, and you can actually, because there are valves, you can vent carbon dioxide and concentrate oxygen. But the problem is, the advantage is you can give a higher percentage of oxygen, but the problem is in the long term therapy, these valves can malfunction. If they malfunction, can cause carbon dioxide buildup and cause suffocation, and they are rare. That is why you have not seen it, isn't it? If you have seen it everywhere, it should be a very common one. And this one, probably you have not seen. But again, this is called a high flow nasal oxygen therapy, where it has a similar interface to a nasal prong, but this is a very expensive and a very efficient gadget. It has its own mechanism to humidify the air, and it can deliver a very high percentage of oxygen. And because it doesn't cause any claustrophobia or symptoms, the patient's compliance is somewhat higher, and close to 100% you can deliver. And this is called a non-invasive type of a ventilation. When you have ventilation lectures, you will see this. There are different types of non-invasive ventilation. I just wanted to show you all the machines that we use, and they can be used in with some other respiratory supports as well. You can actually not only increase the oxygenation, you can support the ventilation as well. You can support the patient's breathing as well, in other words. So these are the devices that you see. And the first device, sometimes these devices, patients have them at home and they sometimes use them at night. You might have heard about these things, isn't it? And if you can you see that this mask is very tightly attached to the patient's face, and with some straps and all these harnesses, and these masks are extremely uncomfortable. Generally, patients do not like them. So that is one of the major disadvantages of this technique, but they improve their oxygenation and can use to improve their ventilation as well. That is why we like these gadgets. It doesn't mean that the patients have to like it, no. So the other problem is, if they want to eat or drink or talk, they need to take this mask off, and there can be a lot of soft tissue injury. If the straps are very tight, it can be very uncomfortable for the patient. Okay, those are the disadvantages that the patient has. And it cannot be used on unconscious patients because there's a risk of aspiration, and sometimes it needs to be converted into invasive type of ventilation. This is what we call invasive ventilation, where we put a endotracheal tube. I hope you have heard about this term, where we talk about endotracheal tubes. And when you have an endotracheal tube, you can actually maintain the patency of the airway, and not only oxygen that you can improve many respiratory mechanics, and you can improve their ventilation as well. But the problem is, there are lots of problems associated with having an ET tube and putting an ET tube, as well as keeping an ET tube for a longer duration. So those are the main disadvantages, but you can ventilate them in different modes. So that is one of the main advantages you have with invasive ventilation. Okay. And there's another, this is the last slide. Actually, this is called, there are hyperbaric chambers where you can use oxygen in a high pressure environment to increase sometimes the delivery of oxygen. Okay. So this is one such chamber. And the monitoring. So when a patient is on regular oxygen therapy, you need to monitor them. So you need to review them clinically frequently, and you need to have pulse oximetry. And if ABG is required, you need to do some ABGs and assess the targets. And you need to always to decide whether to escalate or to de-escalate in terms of fraction of oxygen that is delivered to the patient. Okay, that is because hypoxia and hyperoxemia both are bad. Okay. So these are the complications. We actually have discussed these things, and the drying of the mucous membranes. And as I said, the toxicity depends on the fraction of oxygen and the duration that the patient is on oxygen therapy. So it's like you can't keep a patient forever on 100% oxygen. So anything in excess is bad. That is what you need to remember. And anything in less is also not good. Okay. And that's it. Any questions? Okay. Okay. Okay, thank you for listening then.